Now I'd like to introduce Jack Cohen. Dr. Jack Cohen is the founder of Reprogenetics and the director of Tycho Galileo Research Laboratories, as well as the director of ART Institute in Washington, which runs the joint NIH and Walter Reed National Military Medical Center IVF program. He was trained in the 70s in Erasmus University in Rotterdam, Holland, and as a reproductive scientist specialized in vitro fertilization and cryobiology. He then became the one of the first embryologists to work in Bourne Hall under the IVF pioneer Nobel laureate Bob Edwards. And in 1985, he moved to the United States, first to Atlanta and then to Cornell University Medical Center in 95. And in 95, he moved to the Institute of Reproductive Medicine and Science at St. Barnabas in Livingston. He's the senior editor of one of the founders of Reproductive Biomedicine Online, founder of Altea, and was the North American editor of Zygote. He was also one of the founders of ALPHA, Scientific Reproductive Medicine and Preimplantation Genetic Diagnosis International Societies, and he is associated with several laboratories involved in IVF and PGD, both in Europe and in the US. His interests are developing technology in assisted reproduction, embryology viability, cryopreservation, and developing tests and web-based applications for IVF laboratories. Dr. Cohen has authored more than 300 publications, several textbooks, and 12 patents in this field. He really invented most of the micromanipulation techniques that are being used right now in IVF and that were essential for PGD. And he's obviously one of the pioneers in the field. And he has mentored many of the PGD scientists that are in this field, myself, Jamie, Kelly, and also Alex Vicignano. And he will now talk about PGD, clinical embryology, and evidence-based medicine. Okay.
Thank you, Santi, for your very kind introduction, and thank you for inviting me to give this lecture on evidence-based medicine, which is, I'm not an expert. I'm as much an expert as most of you. And so from that perspective, I will present this topic. I also like to thank Vivera Health and Fertility Planit for sponsoring this lecture. There are some learning objectives. I'll quickly go past this because I think it will become evident pretty fast that what I'll try to do is to give you an overview of evidence-based medicine in clinical embryology. Not as much as in follicular stimulation. I'll focus on clinical embryology and look at the major confounders. What we have done is analyze systematic reviews in clinical embryology. Systematic reviews have been written, produced in the last 12 or 15 years. In our field, quite a few. Of course, they are based on hundreds and hundreds of randomized clinical trials or matched control trials. Haven't read all of them, but I've read a large proportion of them. I was quite shocked to see the status of things and the total absence of rules. And therefore thought it would be maybe a good idea to put this all together. And this has been published in the last months. Actually, next month will be published. It's in Press and Reproductive Biomedicine Online. So what is evidence in clinical medicine? Well, it's considered that retrospective analyses are fine, they're informative, but they're not considered the ultimate evidence. And I think everybody can agree with that. Best available evidence is the randomized clinical trial. It was developed more than 60 years ago. One of the first times it was tested was for streptomycin. And it's very elegant, very simple. You basically have an intervention that you test, that's usually a drug, and then you have a control group that's matched and either gets placebo or not, and the investigators do not know about the randomization or should not know about the randomization, and the patients shouldn't know it either. And so it's a relatively simple thing to do when you're working on the level of a patient involving gametes and embryos. Randomization, blinding, allocation, concealment become more of an issue. It becomes much more complex. So evidence-based medicine originally was developed with the idea that retrospective studies and even opinions would be included. However, over the years, it's become clear that it's only the randomized clinical trial that people will focus on. And this is something I think that's kind of unchangeable, whether you like it or not. Systematic reviews consists of two different types of analyses, and I won't go into the specifics of it. It's the statistical approach that is different. Meta-analyses and Cochrane reports are the major tools that will look at randomized clinical trials and try to assess whether an intervention is effective and is evident or not. This is necessary because it takes, if you have a jump in only 3 or 5% improvement in your endpoint, you can imagine you need thousands of subjects to prove whether an intervention works. And this is the limitation. Hardly anybody, hardly any program in the world is able to do a study that will involve more than 800, 900 or 1,000 patients. Those studies are very, very sparse. There has been one in our field, PGS, the Mastenbroek study that involved about 800 patients, which was a massive undertaking. But I think that's the largest study that was ever done in our field. No study can come close. So you need some system to compare studies and put them in a box and then see if an intervention works or not. EBM is considered to be less effective in complex procedures, particularly in surgery. This is discussed because in surgery, surgical skills are based mainly on experience, but also on skill. These are things that we don't like to discuss very much as medical professionals, but they are an issue, and therefore a lot of people in surgery feel that the EBM procedures are not objectively looking at the procedures and the interventions. Art obviously belongs to the complex group. In actual fact, I would think that it is probably the most complex because it is several interventions on a patient level. Follicular stimulation, which involves the art of saying when an egg should, of triggering ovulation, the egg retrieval, the embryo transfer, these are surgical interventions. And then in the laboratory, there are many surgical interventions on gametes and embryos. And so that whole thing together is not an easy thing to keep constant between intervention and control group. So art clearly belongs to the complex group. Nevertheless, the randomized clinical trial, the RCT, is strongly advocated for clinical embryology. There are many papers about this, many discussions. And again, I think this is something that's set in stone. It's hardly to avoid that. It's hard to avoid that or turn that around. What I will try to do is to show that there are weaknesses in this approach. You probably have noticed this yourself over the years. There are weaknesses in this approach. And that doesn't mean that I say it's not possible. I think it is possible, but the weaknesses have to be addressed. And rules have to be put in place, I think, to overcome these problems. Two editorials that were of importance in this respect. The first one on the top was published in 2008 when André van Sterdegem was the editor of Human Reproduction, where he basically said every intervention, also the ones that are already considered routine by some laboratories, should be investigated with randomized clinical trials. And he made only 2 exceptions to that. One was IVF, obviously. This was 20, 25, 30 years on, felt that IVF was an exception and was proven beyond doubt that that was evident and was a treatment for infertility. And the other one was ICSI. And he felt that everything else, including fertilization, PGS, assisted hatching, any other intervention that had occurred in clinical embryology should be investigated, and one should look at evidence-based medicine. The second paper is the one listed on the bottom. It's a paper published last year, also by Human Reproduction. It's an opinion paper. The senior author is Joyce Harper, and Christina Magli is the second author. These are 2 people who are interested in embryology and genetics, particularly in PGS and PGD, and therefore it's important to mention this paper. I call this the Harper model. Basically what happened in the Harper model is that they raised 7 points of how a new idea should come to clinical routine. And these 7 points are interesting. They're nothing new. You know about these points. You have the hypothesis, you then do research, you do animal modeling, you test. Once you've done the animal modeling and you think you have something, you have a new intervention, you go and look at some donated embryo material, spare embryos, spare oocytes, spare sperm. You then do preclinical small-scale investigations. You then do larger clinical trials, RCTs. So that's the evidence-based medicine portion of it. You then routinely apply it when it's economically feasible or responsible. The last point we could discuss for a long time, and I won't come back to it. I find the last point is a little bit less acceptable because it's very, very subtle, and will be the perception of this will be very different from person to person. But certainly the first 6 make sense. And so if we look at this and apply this to the interventions we know of, you'll see that it quickly falls apart. So here are the 7 interventions. The economics is on the top. The first one is the hypothesis, and then evidence-based medicine is number 5. So if we look at IVF and we look at the compliance, and I've tried to judge it here based on the literature, we look at relative compliance with the Harper model. You'll see here that on 5, there has never been clinical trials done in IVF. That's never happened. Randomized clinical trial to test IVF for an infertility treatment has never happened. So I would think that that is an issue. Evidence-based medicine does simply not exist in IVF. Everything else was kind of in place, including animal research. There are a lot of animals born before Louise Brown was the first baby from IVF. There were a lot of different animals born, particularly in the mouse, rabbit, and hamster. Less so in the larger domestic species. Look at ICSI, then you see even more rat, even less compliance with this Harper model. Again, there, no clinical trials. Very little animal work, if anything. 1 paper from Dr. Iritani in Japan. 1 paper of spare material tested by the group in Norfolk in the clinic that didn't satisfy the requirements for doing the procedure. And then finally, when Palermo and van Sterdegem and others showed that it was a very effective procedure in the human for male factor infertility treatment, it was applied immediately, routinely, by many different clinics. And therefore, I would think, looking at this, that the Harper model really, really is something that we, just from experience, see that doesn't work. If you look at assisted hatching, and assisted hatching is a good example because there have been more than 10 systematic reviews on assisted hatching, over 600 papers, more than 100 randomized clinical trials. So if you do look there, the compliance is much higher than IVF and ICSI, and yet there is still debate now, more than 20 years later, whether this method is effective or not. Look at PGS on day 3, using fish, using a single blastomere biopsy. There is more compliance than for IVF and ICSI, and yet there also there is considerable debate whether this method ever worked or was effective enough globally. If you look at day 5, looking at comprehensive chromosome screening, looking at 24 chromosomes, there too you could argue that the number of randomized clinical trials is increasing. There are now 2, maybe 3, depending on how you look at it. And so that's an improvement. And those randomized clinical trials indicate that the intervention was successful. And there was an improvement of implantation pregnancy, and in one case, even live birth. And so it's a completely different experience from the day 3 experience, where particularly the trial from the Amsterdam group published in 2007 with 800 patients that were randomized in a clinical trial showed a diminishment of pregnancy outcome. So things are turning around here. But anyhow, the Harper model, we feel, provides a set of safety rules. It's kind of an ideal mechanism that you use when you have a new idea. That's what you would have to do in order to come to routine clinical application. But it's a guideline that's, well, first of all, difficult to quantify, Evidence-based medicine is only 1 out of 7 requirements, which probably makes sense. Animal modeling for each method is sometimes not helpful. For instance, in PGS, it's not helpful. Animal models do not exist, except for maybe testing biopsy procedures. Nothing else will come close to the genetics of the human embryo. So there's no other animal model available for us. So I think the Harper model will have a short life and a short existence. So taking it now to randomized clinical trial and the requirements of the randomized clinical trial, there are basically 5. And that's not just unique for clinical embryology, that is for any intervention in medicine. First, you have to do is remove technological bias. Technological bias is, for instance, if you want to test a surgical skill, you do have to have that skill. And you have to prove first that you have that skill in-house. That sounds very obvious, but it really isn't when you look at the literature. Technological bias exists in a lot of randomized clinical trials in our field. A lot, if not all of them, or nearly all of them. Randomization is usually in order. People think, well, if you randomize, scientists think if you randomize, then you're in good shape. But that's just an easy thing to do, of course. You can randomize and have the appropriate blinding in place and have allocation concealment so that the patients do not know in which arm of the investigation they are. And the investigators may not know in which arm of the investigation they are, but that is very hard to do in clinical embryology, and I'll come back to that. The fourth aspect is blinding. Blinding can be achieved in relatively simple randomized clinical trials. It's very hard to do in clinical embryology, and I'll come back to that too. And then finally, a thing like randomization, a thing that's usually in order, but not always, is the analysis and reporting of the RCT data. So number 2 and 5 are usually in order. It's the other 3 that's where the problems are. So the first one is the removal of technological bias. And the first one is like surgery, is the possibility that there's reduced skill or reduced experience, or lack of experience. You have to remove major clinical confounders when you look at technological bias. One of them is biopsy damage. Biopsy damage on day 3 has now been proven, has been shown. Certainly it's not the same for all clinics, and it can vary a lot, but we know very little about it. We can't really say, well, that clinic has a 20% bias rate, damage rate. This clinic has a 30% or 50% or a 10% damage rate. Unfortunately, we can't say that. It's obvious that for day 5, the damage rate is not 0, but it's very close to 0. It's a very different ball game when you do trophectoderm biopsy. So biopsy damage is a major confounder. If this is very high, you should wonder whether a randomized clinical trial should occur at all. The issue with the trial from Amsterdam in 2007, the 800 or so patients who were randomized, was that the biopsy damage in their work was over 50%. And so when you lose 50% of your embryos, to overcome that with a partial panel of chromosomes is impossible. You can calculate that. That just can't be done. So this trial was set up to fail. It's possible that the investigators didn't realize this before they started. They had experience with PGD, but they had no experience with PGS. Their total experience was less than 3 weeks. And that's because, again, not their own fault, because the government told them, the government subsidized this trial. Government told them, well, you can do about 2-3 weeks of investigations, and then you have to start your randomized clinical trial. Poor clinical results is another major confounder. And this applies to clinical applications in general. You see a lot of randomized clinical trials coming from clinics that have poor outcomes in general. Some of them are less than the 10th percentile or the 5th percentile. And I'll give you examples of that. And you should then really argue, well, if you then put a complex intervention in place, what are you doing? They should really put something else in order, which is IVF. They should get that in order first. Maybe they should have a 30% pregnancy rate or a 40% pregnancy rate. I'm not saying that there is a cutoff anywhere, but if it's 5% or 10%, I don't think they should be doing randomized clinical trials And they are rampant in our field. Randomized clinical trials are done by clinics that shouldn't, I think, be doing them. So there should be maybe a requirement of minimal IVF results, not something you like to debate in public. This is not an easy thing to get across. But for this audience, it may not be a bad thing to talk about. So if we look at embryo biopsy and potential damage, there's indirect evidence from cell loss of cleaved embryos after freezing. But it's just indirect evidence because these are frozen embryos. That is not biopsy. We had a paper, there were papers from Australia, where it was shown that there is, of course, damage. It was less so if you remove one cell from an 8 cell through cryopreservation than compared to 2 or 3. And so the debate there was, well, you shouldn't really be taking 2 cells out of an 8-cell embryo or a 7 or 6-cell embryo. And then came the work of Mastenbroek. They transferred embryos without results. And the rate of no results in their work was 20%. And those embryos were transferred without a PGS analysis, which I thought was a great thing, because that had never been done before. Initially, I was shocked about it. But then I thought, well, that's good, because now we can see what the issue is. And the issue was a 56% diminishment, relative diminishment of implantation. And so they proved that in their hands biopsy on day 3 was detrimental. And then the last paper that has looked at this in the most elegant way is the paper by Nathan Treff and Richard Scott and their group in New Jersey. And so what they did is an experiment where they basically transferred 2 embryos to all patients who volunteered. There were 116 patients. The paper was actually published this month in Fertility Sterility. If you look up this month's Fertility Sterility, half the papers are on PGS. Santi showed the first one from David Melton, which says it's alive and well, PGS. Coming from David Melton, that is a shock by itself. You know, when you're a heart patient, that's something you don't read easily, you know. So I was shocked to see that. So apparently things are turning around. And one of the papers is from Nathan Treff about this experiment that was presented a few years ago at ASRM. An elegant experiment. So they take 2 embryos and they transfer these embryos. One they will biopsy either on day 3 or day 5. That is not randomized. So the patients have a preset protocol. They have already agreed that they're going to go to day 5 or day 3. One embryo is then biopsied. The other one is a control embryo. It's transferred. No PGS is performed. No PGD is performed. What they do is they fingerprint that embryo. I remember Mark Hughes 15 years ago had this plan, and we told him that this is something we can't do, because how do you convince a patient to have an intervention without a purpose? And so 116 patients were convinced that this had a purpose. So you can just imagine the effort that was needed to do this. So the embryos were transferred without PGS, PGD. Fingerprinting was performed. Buccal smears were taken after birth. And the embryo was then matched to the fingerprinted embryo or not. If it didn't match, it was the control embryo that implanted. So it's a little bit of a difficult experiment to explain in a minute. But this is what it comes down to in terms of results in the lower line here. You see in red, on day 3, the biopsied embryo had a 30% implantation rate. 30% implantation rate on day 3 is not out of the ordinary. It's not tremendously low. But the no biopsy control embryo had a 50% implantation rate. And then on day 5, it was also in the 50th percentile, both for the biopsy and the no biopsy. So in day 5, there was no significant difference. So it didn't matter if you messed around with the torfactoderm or not. It didn't matter in terms of implantation. Remember, you did not select the biopsied embryo with PGS or PGD, because no investigation was done. This is not embryo selection. So on day 3, you got a very high diminishment of implantation of 39%. Not as bad as Mastenbroek's 56%, but 39% is very high. You know, you lose almost 40% of embryos. I like to believe this. It is a randomized study on the level of the embryo, not of the patient. patients were not randomized between day 3 and day 5. There are a few problems. One is that maternal age is not indicated in this study. And of course, maternal age is highly related to implantation rate, which is the outcome here. Aneuploidy, which is behind it, is not measured. That's not the outcome. Of course, that is also highly related to maternal age. So really, maternal age should have been explained, because what I do not understand is not the one in red, but the number right beside it, which is the 50% implantation rate on day 3, the same as the 2 blastocyst group. Where does that come from? How is that possible? I mean, certainly that is possible if you have a very, very young age group. But even egg donors on day 3, I don't think anybody has shown that is routinely a rate of success. So this is the problem with this particular experiment. Nobody's ever probably going to repeat it, which is unfortunate, because I don't think, again, you can say this is set in stone because of this 50% implantation rate of the day 3 embryos that were not biopsied. Okay, so cut the story short, we looked at we've been looking recently at videos on the internet. I don't know if you look at videos, professional videos on the internet. If you look at professional videos on the internet, you'll find that surgical procedures are advertised on the internet quite a lot. So if you are a patient and you look at surgical procedures that some doctor is telling you you should have, look it up on the internet, because this is how you shop around. A lot of doctors will have their procedures posted. They're nightmarish videos, some of them, and some of them are very, very good. So this is how you choose your people. I would think the skill comes right out of it. And it's amazing that people just post these things. And there's more and more done. And there's also more and more done with embryos. So I've been looking at videos on embryo manipulation for the last 3-4 years. And more and more are being published, posted. And so we're doing currently an investigation looking at these videos. Of course, there are different techniques. And unfortunately, not enough videos. The first time you look, you think there's 300-400. But they turn out to be usually the same ones that are basically copied and posted in different websites. So we did one pilot study so far, which I'll show you the results. But basically, this is I can't really. If you could start the 2 videos on the top, the 2 top panels. Okay. So these are 2 trophectoderm biopsies. The one on the left is done very nicely. However, the 2 same lasers are used. The one on the right, the cell junctions are laced, which is what you should do. The one on the left, the cell junctions are sometimes laced and sometimes not. The one on the right was already finished here very quickly, only 3 pulses on cell junctions. No cells were damaged. And the one on the left takes a little longer. It's maybe a little less precise, and if you look very closely, you probably can't see that. But if you look closely, you see that 2 lyse cells go inside the pad. This is not a problem for the embryo. I don't think it matters if there is maybe lyse material around, but it certainly matters in terms of the sampling. So there are differences there. And if you look at biopsy tapes, not just on day 5, but also day 3, because posting is done day 3, day 5, there are very few polar body posted, only a few. You'll see all these differences. And so we have investigators, experts, and asked them questions related to these videos. That's our study. But what came out from this pilot, where we only used 1 expert, is that if we look at acidified thyroid solution in the green line, videos that were posted a while ago compared to those that were posted recently, you see there is a line of experience. The scores, and that's what you see on the vertical axis here, these are the scores, are getting better over time, whereas with the laser techniques, obviously the skill and experience of the users is less of an issue. And so that's an important difference. So I think lasers are helpful. With a laser, you can easily write a standard operating procedure, whereas with acidified thyroid solution, that's a lot more difficult. So I think this is an improvement in the biopsy technology. Now, about general success rate of a clinic performing an RCT as a potential confounder, I want to take you to this analysis. And this is an analysis of a procedure called IMSI, or intracytoplasmic morphology selected sperm injection. Not very popular in the United States. There's only a few programs that do it. In Europe, this is popular. In the Middle East, this is popular. In Asia, but not in the United States. And therefore, it's maybe a little easier to show this to you because I think this audience will not be very biased about IMSI. And so what we see here is that there's only one systematic review of IMSI procedures. There are hundreds of papers. 37 papers of those hundreds were considered for this meta-analyses done by a group in Brazil. 5 were considered and 3 were selected. This is normal in systematic reviews. You start with hundreds of papers, eliminate 90, 95, 97% is about the average. 97% is eliminated. In the beginning, if you're involved in one of these studies, or if you're involved in actually proposing the intervention, it kind of hurts when 97% of the papers are eliminated. But now I think that's not enough. And maybe I have some time to get back to that. So 97% is eliminated. In this case, that was the same. 3 were selected in the final meta-analysis, and they proved that implantation improved, pregnancy rate improved, and there was a decrease in miscarriage rate. In these male factor infertility cases where what IMSI does is magnify the sperm that's being injected during ICSI. You get a very, very beautiful picture, and you can avoid sperm that you maybe normally would select, but not when you see it at this high and precise, more focused magnification. So when you look at these papers, and you look at the results of the control group, there are 4 papers here, not 3, and it's because I looked at papers. The paper was from 2010. I looked at papers since then and found one that probably should be included. The authors, considering the criteria they used, they would have probably included this 2011 paper by Wilding and others in Napoli in Italy. If you look at the control varies in implantation rate between 9.4 to 14.8%. And if you look at the age in the 4th column, you see that's the average age. So these are very young patients, all of them. Now, if you look at IMSI, there's a very clear, significant improvement in implantation in each of these studies. The meta-analysis showed, indeed, as I showed you before, that there was a clinical improvement. But now when we look at the SART reports, because you need to sort of compare this, what is the norm here? Because the control groups looked so low. So look at the SART reports, we have Alex Bessignano and Kelly Catterson and I have produced a website called ivfreports.org. And with this, this website, you can actually look at the SART data independently and mix the results and look for certain trends and outcomes. And if we look at implantation rate for the average clinics in this country, we found in the last column that the implantation rates were significantly higher, with an average of about 3 times higher than all the control groups in these studies. This is probably the reason why embryologists in this country are not that interested in IMSI, because they looked at these studies. I've talked to a few, and they said that, but we looked at the first studies, the Bartov study from 2003, the Berkovich study from 2006, and they were so unconvincing in terms of the control implantation rates that the intervention implantation rate was still lower than what they had normally with ICSI. And so then you become less interested. And so what has happened here is that the intervention is not impressive, in spite that it is significantly better over control. It's not impressive compared to the mean SART implantation rate. Of course, these are different countries, but it is impossible to argue that these are groups from Israel and from Italy, that in this country the implantation rates will be 3 times higher than in those countries. That's not the case. It's not even double. It will be a little higher probably, but not much. And so something is going on here, and I call that the magic control group. That's not typical for IMSI. It's typical for most interventions that are studied. So these control groups vary. We had one from New Jersey before. There the control group for day 3 biopsy was 50% implantation. That's higher than what you would expect. And so, yeah, magic again. Certainly not done on purpose, but something happens in the intervention, maybe not enough subjects, so that these outcomes change. Then there is randomization. Okay, randomization is usually in order in randomized clinical trials in clinical embryology. Patient randomization is not very complex, but you get a very small sample, eggs, oocytes, embryos. That's more tricky to randomize, but the advantage is clear. You get a very large sample. So there are hidden allocation confounders. These are different for each stage. For instance, in egg collection, if you want to randomize oocytes, you have to look at the duration of egg collection. There are practitioner preferences, suction differences, temperature drifts. So how are you going to select the oocytes? So allocation bias can be minimized using a set of rules. For instance, you can pool and randomize using a witness. And you can finally, when you have the eggs and embryos that you want to randomize, you can take them out of focus and then pipette them. I don't see those things ever mentioned, but it would be very simple to get over this problem. It would be very easy to get it randomized appropriately. Allocation concealment is a much bigger problem. So that's where you hide the randomization process to patients and investigators. PGD trials, PGS trials are the most complex in embryology. The non-selection approach from Richard Scott's group is a very informative way of doing it. It's objective, although a little controversial. But how do you conceal an easily detectable treatment in embryos? So if you have a hole in the zona pellucida, or if you've taken a cell out, or you have done trophectoderm biopsy, or you have a post-vitrification embryo, any embryologist can see that this has happened. So where's the blinding? There isn't any. No mention of that in the literature. None of the papers mention this, that this is obviously was not achieved. Can it be achieved? Yes, but I think you have to have a lot of people in place, so it's a very difficult operation with witnesses, making sure that bias doesn't occur. So allocation of treatment concealment is absent for more than 99% of RCTs. I think it's 100%, to be honest. So is the RCT suited for embryology evaluations? I think it is, but you need to make modifications. Finally, blinding, masking of participants, investigators and outcome investigators. This can also be done. There are issues, but they're not insurmountable. The level of blinding, there's this organization called Consort that gives you the level of blinding. They have actually said, forget about single-blinded and double-blinded, triple-blinded. Nobody understands what that means. You have to write it out. You have to describe in the paper what you mean by blinding. I think that's a good development, particularly that will work well in clinical embryology. Okay, now very quickly over some specific, I don't know how much time I have if I'm running over. I'm done. I was done a long time ago. Okay, okay. Okay, I only want to show you this because what is the issue in PGS and PGD? There have been meta-analyses and they're all our own fish in day 3. And of course there, the dominant trial of 800 cases takes over everything in the statistical analysis. And this is not right. What you have to be fearful of is that with day 5 and trophectoderm biopsy and comprehensive chromosome screening, things working so much better. There are already a few trials that show this, that the technocrats, the people who are interested in systematic reviews, are going to put it all together. If you do not believe me, that is what they do. And here is an example of how they put it all together. So this is not PGS or PGD or assisted hatching. In assisted hatching, they put everything together too. And that's why it will be another 20 years before they finally figure it out. They've put every technique, every non-validated technique together and come up with, well, so far the left birth rate is not making a difference. So here, this is embryo culture media, where there are hundreds of different randomized clinical trials. This is from the Amsterdam group because they publish more meta-analyses and Cochrane reports than any group in the world. And so they did this very, very impressive meta-analysis this year on embryo culture media. There are 3 types of embryo culture media. The first ones go back to the 19th century, which are the type 1, what I call type 1, which is salt solution based, such as Witten's media, thyroid solution, Earl's balanced salt solution. Type 2, which are the back to nature variants, including the sequential media. So Menace's B2 was the first one. HTF was the most famous one we have used. A lot of thousands and thousands, if not 1 million pregnancies from HTF. And then the sequential media, which is a variation of thereof, particularly Gardner's media. And then there's the type 3, the simplex optimization media, which are based on a large budget and a lot of science in order to get the answers. These authors of this systematic analysis did not look at the type of media. They just compared, they had a randomized trial, they compared one brand with another brand, not even knowing where the type of media was. So they have come to the conclusion that it absolutely makes no difference what media you use. That's published in Human Reproduction. It was a feature article. And I think it's completely wrong. And this is what's going to happen if we don't be careful. This is what could happen in PGS. The meta-analysis, start writing it if you know how to write a meta-analysis. Or if you have time or if you have the budget, start writing the meta-analysis, because it should just be on PGS on day 5 with tofectoderm biopsy and comprehensive chromosome screening. If you just do comprehensive chromosome screening, you can do qPCR, you can do NGS once you get the trials, and you can do the array CGH. You can put it all together because you just have results on 24 chromosomes. So I think that's fair to put it all together. But if you leave it up to the technocrats, they're going to put everything in it, which means you'll never get over the 800 cases from the Mastenbroek paper in 2007. Thank you.